Welcome to Stemless Faceoff podcast. We're here with Dr. Osborn and Nicole, my co-host. So we're gonna dig a little bit into this semi-glutide.
Okay.
Um,
Yeah, I'll leave it now here to answer your questions. It's a very, very, questions surrounding semaglutide are commonly asked. It's like every day. And my view of it is very, very, I would say it's contrarian to most who tend to vilify the medication. It was actually just, did you guys see the recent interview with Tucker Carlson? Did you see it? No. There's a guy on there. I don't know his name. You can find it. They probably spoke for half hour or so on why it's a bad drug. The problem is that when you have people that are sort of outside of medicine telling you that, in other words, having watched people die from these diseases that are sort of rooted in obesity and just being overweight, those people are not qualified to talk about it, as far as I'm concerned, but they do. As a matter of fact, I would tell you that the majority of people who are commenting on these medications on the internet are poorly qualified to do that. When I'm on neurosurgery call, in other words, cranial call, um, there are a whole host of patients that come to the emergency room with hemorrhages in their brain from hypertension, as an example, which is, as you know, to a degree related to being unhealthy, overweight, obese. These diseases are all very, very similar. So if you could give somebody a drug that's going to mitigate their risks for being overweight, developing cerebrovascular disease, so atherosclerosis, arteriosclerosis of the small vessels of the brain, which predisposes them to hemorrhages. Well, why wouldn't you give them this drug, right? And people say, well, what happens when you stop it? Or it's going to cause nausea, or it's going to make you malnourished. Well, the answer to those questions are, you're never going to stop it. If you have a good doctor, you're never going to get any malnourished because they're going to reduce the dose, or they're going to reduce the frequency like we do. And yeah, you will get nauseous from it. But again, you do the exact same thing. So in my opinion, and this is where it's very contrarian, but I say this publicly all the time, everybody, unless you are, say, Karen Carpenter and have some sort of eating disorder, bulimia, anorexia, everybody should be on a very, very low dose of this medication because, and you guys will testify to this, I'm sure, because you train people like this who want to get into shape, right? Most people can afford to be a little bit leaner, and most people can afford to eat a little bit less. And that's just the bottom line. So if you had an agent, even if it's a drug, because people get nervous when they hear the word drug, and it could drop people's weight, even if it's, somebody that's 20 pounds overweight, you can just knock that 20 pounds off and then just keep them on a stable dose, so normalize them. And they just need to stay on a dose of semaglutide that's just, let's say, really, really low. So we'll just go to 0.25 milligrams, even if you use it every other week, every third week, every fourth week, which is totally off label. But we do that in our clinic all the time. I would argue and say that everybody should be doing that, right? Everybody's should be doing it. You're going to dramatically lower your risk for the development of these diseases. And what I mean diseases, I'm talking about things like, forget about the obesity and just being overweight and things like that. I'm talking about your blood pressure goes down, your lipid profile improves, and there are data, okay, that you can, it's easily mineable, that show that it dramatically reduces your risk of stroke and heart attack. Why wouldn't you be on these drugs? So the people that say, well, we shouldn't be putting people on these drugs, why not? It doesn't make any sense as to, not using these drugs. It just, in my opinion, everybody should be considered when you go to your primary care for some medication like this, whether it's semaglutide or whether it's liraglutide or whether it's one of these other offshoots, because we know that hospitals are filled with people that are not afflicted by infectious diseases like it used to be, say, 100 years ago, in the advent of antibiotics, and then we were able to treat those problems, right? I'm talking about garden variety pneumonia, tuberculosis, things like that. Now we have remedies for that. People don't die of infectious diseases anymore unless you're in a third world country, right, where their antibiotics are limited, right? We die of diseases that are related to obesity and being overweight, period, right? So the other thing that I always say to people, and again, it's sort of it's brash, is I think ultimately that these medications will have the impact nowadays when we look back that antibiotics had, say, 75 years ago. Because again, we're not dying of infectious diseases. We're dying of man-made diseases that are related to poor nutrition coupled with a relatively sedentary lifestyle. Period. Go to the hospital and look around. So that was a long-winded answer to your, not even a question, but I just wanted to just sort of clarify sort of how I think about these drugs. And anytime somebody has some sort of opposition to these drugs, I would always, default to what I just told you. Namely, there's no reason why people just in general shouldn't be considered for these drugs. I don't care if they're carrying around 10 pounds of extra body weight and it's a small amount to lose. Sure, they should strive to eat well, right? So a low glycemic, anti-inflammatory diet is what we push. And our patients that are on semaglutide or whatever it is, Saxenda or Wegovy, we're always pushing them proper exercise, technique, strength training, proper nutrition. So these things go hand in hand. But the bottom line is that the majority of people, they have very, very minimal accountability to other people, to themselves. It's very, very hard. They're not disciplined, right? So people are people, right? So the people who say, like this guy on Tucker Carlson, he said, don't put people on semaglutide, let's say, Ozempic. Instead, teach them this, that, and the other. We do. But I'm just going to tell you, again, he's outside the clinical. Mm-hmm. And if you're outside the clinical, you don't really realize how bad, people are in the context of their eating and their exercise regimen or lack thereof, mm-hmm. right? So the reality is that you're treating a human, people are people, right? They tend to do badly in both of those sectors from the standpoint of, mm-hmm. nutrition and exercise, right? So use the semaglutide, knock the weight off of them, and then just taper it back so that they're on just a teeny dose, and still teach them proper training, proper nutrition. Those things, one does not exclude the other. In other words, it's not go on semaglutide and then forget about the rest. No. The same exact principles that are in the book, as an example, are taught to our patients, and they're still on semaglutide. And we've had nothing but unbelievable results, right? Sure, some people complain of nausea. We scale the dosage back or the frequency back. It's okay. But the results are nothing, with these medications, are nothing short of transformative, period. These drugs, unto themselves, even absent modifications of nutrition and exercise, have the ability unto themselves to, I'm not going to say cure the obesity problem in this country, but make a huge dent in it. A huge dent. That's how impactful they are. So what was the genesis of what was the impetus for the question? People asking you about it?
Can someone build a resistance by usage of the...
So that's a good question. We do see people over time. So they'll lose a bunch of weight. I had a guy in my office yesterday who was actually a family friend. He's a patient and family friend. And he said, I'm at 1. I don't know if you know about the dosing. Mm-hmm. And this is semaglutide. This is Ozempic. Wegovy is different. They're all different, okay? Mounjaro is different, dosage-wise. But he said, I lost 30, I think he's 30 or 35 pounds down. He's got about 15 more to go, and he's on 1 milligram. You guys know that the dosage starts at 0.25, goes to 0.5 in 4 weeks. And then we typically will escalate it up to 1 milligram. He's at 1 milligram. He's been on for about he's been on for about 6-7 months or so. So he's had a nice weight loss, 5-6 pounds a month, nice. Not too aggressive, and I don't like aggressive weight loss, not too aggressive. And he said, the one isn't really working much for me. I'm not having this suppression, anymore. I said, that's okay. Just go to 1.25, 1.5. And that's all we really see. I would say that most people, they start developing a little bit of resistance, but that's after they've lost all this weight, right? So it's a negligible sort of problem that we have in that regard. It's not like, oh my God, somebody's at, the high dose, right? So, they're up at 2 milligrams or higher, and they're still 100 pounds overweight, and they're not having any suppression. It's unusual. If they do, and it's really unusual, we switch them to Manjaro, which has two of the incretins in it. So as opposed to just the one incretin in semaglutide, it has two. So it's GLP-1 plus another one. So, and that tends to, I would say, turn the switch on a little bit harder and drives the weight loss for them.
Oh, wow.
So we have, I always tell people this, and it's just true. We have zero failures in the clinic. Did we have a lot of failures in the clinic as far as people trying to shed weight prior to the advent, of these? We've been using these for about 4 or 5 years now, so long before other people were using them, as I told you. We really haven't had anything, but like I said before, we would use counseling, strength, you know how it goes with counseling. You're smiling. I see Nicole like, that doesn't work. Well, because you guys have your own clients and you guys know what it's like, right? And we would use metformin, which is pretty aggressive, but it doesn't have the appetite suppressing effects. It just drives your insulin levels down, which, as you know, is a signal to burn fat. And people do lose weight on it, but not nearly as aggressive as when you actually zip somebody's mouth shut. Which is what these things do. They really just zip your mouth shut. I don't know if you guys have ever fiddled with them, but the signal is aggressive.
I've been on these things. Your brain from thinking,
That's right.
I need food.
That's
what
right.
should I eat
That's right.
today?
That's right.
What could I eat
That's
now?
right.
Oh,
It's
doesn't that
really,
dessert sound
right.
good?
It's really, really, really an aggressive signal. It's really aggressive, almost to the point of being dangerous. Which is why in women we have to be careful, because women typically, not you guys, but a lot of women don't have the horsepower, the muscle, and they don't realize how important it is to eat. So what they're constantly looking at is they're looking at the scale. And I always tell the women, get off the scale. Take the scale in your bathroom and throw it out. You come and you can get on our scale, so we can look at your anthropometry, so we don't want to see them losing muscle. Right? But then again, they're concerned about just what that scale shows, which is dangerous. So we have to be careful, mainly with the women, less so with the men. So that's the one little caveat. And everybody, particularly the women, should be on a multivitamin so that they don't lose their hair. Because some of them do, because it induces the semaglutide or whatever incretin you're using, induces a relative sort of a state of malnourishment. So you have to be careful. But you can avoid that by just coaching them up and telling them, look, we're going to drop your dose down, right? So that you don't have this problem. We're watching their bone density, we're watching their muscle mass on the scale, and we're asking them about their hair, and if they're having issues with it, we'll continue to drop the dose down and tell them, so they eat a little bit more. Tell them, look, you're gonna have a problem. Mm-hmm. That being said, if you do start losing your hair and you reduce the dose down or stop the medication, if you wanted to take a hiatus from it, your hair comes back. It's not a permanent thing, but I don't even want to see it. So women, especially, we're very, very aggressive. Multivitamin, a multi-pill multivitamin, not a Centrum, which is garbage. Like something from, and I'm not affiliated with them, like Life Extension. We're using 9 capsules a day. You split it up, and it has, the micronutrients in it, the coppers, the zinc, things like that, things that are important for hair growth. Okay, the biotins, things like that. Not some single pill multivitamin. And we try to encourage them to meet their macros that are assigned to them in the clinic, despite the fact that their appetite is suppressed. And strength training, so that they mitigate the muscle loss. Because as soon as you become hypocaloric, you know what ends up happening, right? You start losing muscle. And that's dangerous, and I don't want anybody losing muscle in the clinic. We do have people that do, but then we talk to them and tell them, this isn't working, we're going to back your dose off. You got to start strength training more aggressively, and you got to start eating more, despite the signal. Just as Nicole said, it is. Have you tried it?
Mm-hmm.
Yeah, it's aggressive. I mean, I was on it for a while because I always take all the medications that my patients take. It's one of my sort of, I feel obligated to do that. I'm like the guinea pig, the crash test dummy in the clinic. It's true. I mean, I was down in the 170s.
Wow.
Yeah, I was very light. And the problem is that, you get weaker. And I don't like, I like powerlifting, so I don't like being, it's true. I mean, it's just true. So you got to be careful with it. But all in all, I think that if you're under proper supervision, not getting it from one of these chop shops or online, and that's, I think, where a lot of the bad press comes, because they buy it from somebody, one of these peptide places, right? And then they're using it themselves, right? They have nobody watching them, then you have a problem, right? But I think that if you do it properly, under medical supervision, if your doctor's experienced, you're going to be good. I don't see any downsides, with this medication. I really just don't. And it's not like these are new. These have been around for about 10 years. This is not new. It's new to the media, but they are not new. So there's a pretty good track history with these. And with metformin, which is another diabetes drug, as I'm sure you guys know, that's been around for 7 or 8 years. Right? So we were using that aggressively. That's why in the book, I didn't talk about the incretins. They were less on the radar at that point because that book was written 10 years ago. But metformin, and at that point I had been on it for, I don't even know how long, probably 5, 6, 7 years at the time the book was written. And again, the book was 2014, so I talk about metformin in there. People go, whoa, what are you doing? Diabetes medications for people. Yeah. And we use it in the clinic now. We do, for somebody that doesn't want to go on the semaglutide. If they just have just a teeny little bit of weight to lose, they don't want to start with the injections, we just put them on metformin, which is what we used to put everybody on anyway. So medications I think are spectacular, and they'll continue to get vilified in the media, and I think that's just because the people that are commenting upon them are either not really in the space, have never actually been next to somebody, held somebody's hand when they're dying, from some sort of disease that's related to obesity, or they just don't understand what they're talking about. Right. That's it. And then I will fight to the death about this because I've seen it work in the clinic, and I've seen the other side of it with my neurosurgery patients. It's just the truth. Does that make sense? Mm-hmm. So that's my stance on these medications. I mean, I think that they are really, really, really important additions to our current armamentarium. Forget about the obesity problem. Every other disease, obesity is a gateway disease to all these other diseases. So if you can treat the obesity, or get these people on semaglutide, blood pressure goes down, lipid profile improves, stroke and heart attack risk go down. There's a ton of data on it already. I don't think that cancer is not going to be following suit. That'll happen because, as you know, cancer is just a nutritional, it's a metabolic disease. It is, to a great degree. I'm not talking about childhood cancers, which are genetic. I'm talking about cancers in adults. Okay, to a great degree, their genesis is in flawed metabolism, right? So eating too much sugar. Cancers, they feed off of sugar. This is a fact. Right? When they do PET scans on people, they're injecting sugar into you. Right? It's radioactive glucose. It goes right to the tumor. They don't inject fat, right? Because cancer cells don't know how to use fat. Right? So that's why if you want to go on like a cancer, what would you call it? Like a chemopreventative diet, it would be a ketogenic diet. Your body's just metabolizing fat very, very rapidly. And glucose levels, stay nice and low. Insulin levels stay nice and low. Insulin's a growth factor, remember. More insulin, more growth. In a bad way. Bodybuilders use it, as you know, to grow their muscles. It's very anabolic. But tumors also like it. And they grow. That's why cancer rates in diabetics are much, much higher than the general non-diabetic population. Right. So don't think that's not going to happen. And also, these drugs ultimately are going to be used for, in my opinion, there's early data on it, addiction. Right. Food addiction is no different than alcohol addiction. What about gambling? It's already happening. It's already happening. Anybody that has any type of addictive sort of behavior is probably going to be on one of these incretins, and it may be semaglutide or maybe some sort of offshoot. I'm sure a pharmaceutical company is working on something for it. Smoking, maybe. Alcohol, yes, because our patients that go on semaglutide and that are drinkers, they stop. They do.
That's great.
Yeah, we see it all the time. They just stop. They don't have the taste for it anymore.
Yeah, that's what I was going to say.
Yeah, it's gone.
You drink it and you think,
Yeah, it's gone. So, I think that these drugs are beneficial. Sort of, there's a whole gamut of indications I think that are going to be described or found, for these medications. That's what I think. It's not just diabetes drug. No, it's going to be a whole host of things.
That's amazing.
So yeah, they're really neat.
So is this peptides your body metabolizes or stays in your system? How long does it stay in your system for?
It's a good question. For quite a while. Yes, the body does metabolize it, but once you are on a stable dose of, again, we'll call it semaglutide or Ozempic, whatever you want to call it. What ends up happening is that if you were to stop it, and people do, they fiddle around. Excuse me. Before they start feeling their appetite come back, I would say it's between 3, 4, sometimes even up to 6 weeks of suppression, which is why we can get away with, if somebody, is sort of approaching their ideal body weight. Because I always ask people, when you were in your best shape, what'd you weigh? And they'll say, oh yeah, well, I was in college. And they're starting, well, I'm just saying, and they're creeping down. You see them, they're coming, into that weight. They're 15 or, they had to lose 50. Now they're 30 pounds down, at the year mark as an example, and they're getting close. We'll start backing them off. And because I know that we'll just call it the half-life is long. These are once weekly drugs. You could do it every 2 weeks, every 3 weeks, and they'll just sort of approach. It's like landing a plane. They sort of just come in real slowly like that, and they'll just go like that, and then it'll stabilize. Yeah, and you're exactly, and then that's it. And you can fiddle around, with the doses, and we cautiously encourage our patients to, again, under our supervision, fiddle around a little bit, because you don't know. Everybody is different, right? Biochemically, we're pretty much the same, but there's going to be some differences in metabolism of these medications. So what we do is we tell people, look, you're on 0.5 now, you've lost 30 pounds. Go down to 0.25, go down to 0.35, and then, start skipping a week. Pay attention to your appetite. Take a look at how you look in the mirror, how your clothes fit, right? And start fiddling around with that dose until you start sort of, you're wiggling, you're getting closer and closer to that, that dose, and you're homing in on it, and eventually you sort of figure out where you need to be by fall. Yeah, so that's what we encourage our patients to do. And again, these medications, despite what you hear in the media, they basically can't hurt you, at least with the data that we have now. In other words, people aren't growing tumors, they're not growing horns out of their heads or anything like that, right? And again, these medications have been around for a while, about 10 years, right? So you would think that you would see things already. We don't. So you're really not going to get hurt. Yeah, you do have the people who say, well, you're going to get pancreatitis from it. Haven't had a single case of pancreatitis from semaglutide. I've been writing it for years. Knock on wood. Do we have people that call with nausea, vomiting? I vomited from it before. I had to stop my car actually one time on the highway. We opened the door, vomited, okay, and kept going. But, I know what it is, and I know, okay, next week, take less. And when people call and they say, I'm nauseous or I threw up, if I happen to feel the phone call, which I typically don't, it's usually my nurse practitioner, but if I happen to or they want to speak to me, I'll say, it's working. The medication is doing what it's supposed to be doing. Don't be put off by it. Don't stop, because we did in the beginning have people stop when they got nauseous or they vomited. And I would tell them, look, that's what the medication does at the the level of the brain. It causes such an aggressive satiety signal. It'd be like you eating like 10 plates of spaghetti. You'd vomit. Your stomach is so distended, you're going to throw up. That's what you have in an injectable, right? So if you take too much for you, or if your system is not used to it, or if you eat a lot of fat, which slows gastric emptying, right? It's slow. That's why you tell people to eat fat. It's going to make you full. It slows, the emptying of the stomach into the small bowel, right? It's going to create a satiety signal. That's why people should eat salad with olive oil before the meal, right? We figured out instinctively to do that, right? In other words, before we knew anything about nutrition, we realized have a salad before the meal. Nobody knew about what was going on biochemically 100 years ago, but we were eating salads before meals, right? There's a reason why. It's because it gave us a satiety signal, and we probably could just eat less. And that's because of that, it's really the fat that slows, and the fibrous vegetables slow things down, as you know, in here, and that's going to give you that satiety signal. So, Ozempic, semaglutide, Wegovy, it's just that signal in an injectable, but you got to be careful with the fat because it's going to overdrive that system and it'll cause you to be nauseous. So if you are on Ozempic or any of these things, and you have to eat, like if somebody's programming your macros, I don't know if you guys program people's macros here, but if you do, and you have them on just to say 100 grams of fat a day, which is, it sounds like it's a lot, but it's not that much. They split that throughout the day. They don't just go and they have, 50 grams of fat in one meal because they'll be nauseous. So you just tell them to split it. And they can have their fats, in 4 separate feedings, 25 grams at a time, and then they'll be fine. All these little things that have happened with semaglutide, whatever you want to call it, these incretins, we pretty much have dealt with at one point or another, and none of them are grounds for stopping the medication. As a matter of fact, I think that's absurd. It's short-sighted. Right? You should be on these medications, just learn how to use the medications properly. Even if you're taking just a teeny bit. I have one patient who takes 0.25, lost all this weight, 35 pounds. Now she's teeny, okay? She takes 0.25 every 6 weeks. That's it.
Nice.
And she's great. That's it. So it's a small amount. The other reason why, you hear, about all these sort of, untoward effects and, it's killing me, it's because the doctors who are prescribing it, they're not, I'm not going to say they're not paying attention. They're just maybe less experienced with it and don't fiddle. So what they do is they'll put them on 0.25, go up to 0.5. They'll keep going. And as per the standard sort of dosing, the person's nauseous and they're like, no, just keep going up. No, you can't do that, right? So you have to just use your brain, right? And realize, hey, this person may be exquisitely sensitive. Maybe they just need 0.5 every 3 weeks and they're good. And then all these side effects that you hear about, right? They go away. Sharon Osborn looking, come on. That's a bad doctor. I don't blame her. She probably didn't know any better. That's a bad doctor. That's terrible. Right? That should never, right, that shouldn't, you think? That should never happen. Never. That should never happen. We have no patients in our clinic who are even close to that. We do have some women who get a bit thin, and we just tell them, look, you got to eat, right, or else we're going to have a problem, and you're going to end up with osteoporosis. You start losing your hair, right? Face starts looking a little bit gaunt. We just back them off. We just did that once this last week. I had to back somebody down. Came in, had lost about 30 over, actually this is, she'd been on the program for a while, so even before using the incretins, she was on metformin, I believe, and she lost about 30 pounds. It was probably over a course of about 3 years. She weighs about 115. She's probably 5'6", so getting to the point where she's a little bit, right on that edge. So we had a conversation.
115.
Not very muscular though. She's not like you guys.
Okay.
No,
Okay.
not like you guys.
Okay.
No. She's actually not like you guys. She's about. We did some calculations because I was showing her. I always tell you guys that women should be about 45% muscle. You guys are both in that category for sure. She's in the low 40s, and I don't like it. especially as you're going into, and she's about maybe a little younger than me, around 50. And as you get up there, I think we talked about frailty and how bad it is to be frail. Frailty is associated with cognitive decline and fall. Most common cause of head injury in somebody that's older than 50, by far, is a fall, right? That's what I deal with all day, every day when I'm on call at the hospital, right? It's extremely dangerous. When you become frail, you get stupid. You have a tendency to fall. Your bones are brittle, you break your hip, and you're dead. Cannot get frail. Cannot. So I appreciate the fact that everybody wants to look good and be teeny, but not, when it's coming at the cost of you sacrificing your muscle. That cannot happen. That cannot happen.
Muscle is youth.
That's correct.
Right?
That is
Oh,
correct.
yes.
That is correct. It is your resistance. It is your to disease. It is your resilience. Muscle, you cannot lose it. Yeah. And you look at people, once they start getting up there 50, 60, they have no muscle. They're done.
No. Yes.
That's why people say, when am I going to stop if we put somebody on testosterone, a lot of our men and women, never. Why don't you do that?
Right.
Your body's no longer producing
right.
it, so you need it.
Right. Why would you do that? It doesn't make any sense.
Yes.
It doesn't.
Everybody wants, that's a very common question for a lot of things, so. When is it finished? When do I finish?
Yeah.
When does it end?
Yep.
How long do I have to?
We get that question all the time. And I always tell people,
it's a lifestyle.
Never. Your biochemistry is going to falter, right? So you start getting, I have a cool graph in one of my slides. Your body's going to falter, and as you 50, 60, 70, and just starts, this is quality of life on this axis here. And this is age, quality of life just starts. And then, you're 60, 70, 80, right? You're living in this sort of this semi-decrepit state. You're becoming progressively frail. Strength train heavy, eat properly, make sure that your biochemistry is right, if that includes hormones. And for most people, it's going to, because the body sort of acts one way and the hormones go down, despite what we do in here. Do everything that you can to get everything optimized so that you can, we call it square and lift that curve. So instead of it going like this, your quality of life goes like this. And instead of, dying in this sort of decrepit state, 70, 80, 90, you're sort of going down, 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 living your last 20 or 30 years in this decrepit state or semi-decrepit state. Crash your Ferrari into a wall when you're 90. That's a good life, right? Well, that's what you should do, right? That's what you should do, right?
You're still way up.
That's right. And you're 90, okay, and you're going 120 on your Ferrari. Great. Okay. Not when you're doing this and you're in your wheelchair in your 70s, 80s, and there is no quality of life at that point. But take a look at what's going on. That's exactly what's going on. 50% of Americans, it's believed, are living on the downslope of that curve. 50%. 50. It's a huge number. And I'll tell you, the majority of those, they could be rescued if they knew what was going on, if they paid attention to stuff that you guys are, talking about in your podcast, just doing these things. But a lot of people are lazy. If they're lazy, they don't have the means, they don't have the access, but information now is so well disseminated. I would say that the access to information is so easy now that you can't sort of hide behind that one. Oh, I didn't know. That's not
true
anymore.
Cell phone?
Right, that's not true anymore. Right,
Yeah.
or it's less true. I mean, it really is. But yeah, I mean, these medications they're not going anywhere. And I think that their indications are going to be expanded as time goes by. And I'm not some sort of, conspiracy theorist. We use generics in our office. I don't care about big pharma, I could care less. I just care about the patients, right? And I think that honestly, these medications are going to be found to affect a lot of the disease states. As I had said, alcoholism, anything that has some sort of addictive property to it, alcoholism, maybe smoking, gambling, eating, obviously, right? And, secondarily, diseases, the incidence or the prevalence of diseases just across the board should go down. I'll tell you who should be scared, the food industry. It should. I don't know what the data, but I guarantee you, if you look at it, I guarantee you just across the board, I don't know what metric or KPI they're using, but I guarantee you their stuff is starting to go like this. People are, yeah, that's right. People are eating less.
Oh, yeah.
because of these drugs.
But you save money by going to semaglutide because the food is so expensive now.
You do.
It'll quiet your mind.
It's a good point. And I honestly don't believe that if everybody sort of, if physicians sort of start adopting this type of attitude, I honestly think that we can make a big dent on these disease processes. I really, really, really do. But a lot of physicians are just not. They're not having it. You know, they're just not, because it's a conspiracy theory. You know, everybody's on these drugs now. Well, yeah, because they work.
It's one drug.
Yeah,
And
it's-
so many
Off
people
5
are
or 6
overweight.
other.
so many people. 70 to 75% of Americans are categorically overweight or obese. 70 to 75%. Do I think 70 or 75% should be on it? Yeah, and actually probably even more. Probably even more. Again, just from the standpoint of maintenance, you know, maintenance, because of the downstream effects of these drugs. They improve your lipid profile, right? Bring blood pressure down, reduce heart attack and stroke incidence. So even if you're 5 pounds overweight, right? I don't care. Then take a teeny bit of this drug, you know, every so often, every 4 weeks, every 6 weeks, just so it knocks it down just a little bit. Right? Just a little bit. I'm not telling you everybody should be on full dose Ozempic for the rest of it. That's unnecessary. It's unnecessary. But teeny little bits. It's like I believe everybody should be on metformin. It's just, I do. You know, prior to these drugs, everybody in my clinic, 99% of people were on metformin. It drives insulin levels down, right? Keeps you leaner as opposed to heavier, right? You'll lose 5 pounds, lose 10 pounds on it. I'm serious,
Yeah.
you know? And they're non-diabetics. 95% plus of my patients in my clinic are non-diabetics. I'm not taking care of sick people. I'm taking care of people to prevent them from getting sick.
Right.
As you know.
And isn't that ultimately what it should be?
Correct.
It shouldn't wait till,
Correct.
oh, now you're
Correct.
sick and.
That's right.
Let's
But-
see
Which
how we
is
fix
what it is. Right?
Human
We live in a
nature,
reactive
really.
medical environment, right? Not a proactive medical environment. Yeah. And it's part of it. You know, even being on semaglutide, you know, you don't have to even be pre-diabetic. You don't. You just have to be, although, you know, obesity and being overweight oftentimes is associated with a pre-diabetic state. You know, they're insulin resistant, but, you know, people that are not even there, right? Just people that are carrying an extra 10 or 15 pounds are, hey, exercise, nutritional modification, maybe just some low dose semaglutide, you know, and just let's get that weight sort of normalized. And then we'll talk about maybe, you know, you coming off the medication. But I would tell you that I would probably say, nope, just be on small doses at very, very limited frequency and leave it alone and stay on it. Because it's going to take that 15 pounds off of you or that 10 pounds off you, and the maintenance will keep it off.
Instead
And
of
that's
waiting
what you
until
want,
you're so
right?
overweight.
That's what you want. So those are my thoughts. I know it's long-winded, but I have a lot to say about the drug because we're so sort of attached to it because we've seen, you know, the positive effects, the benefits of this drug, and ultimately we will see this manifested in hospital admissions and patients that come in with these hemorrhages and all these other problems, you know, that I'm involved with sometimes. Most of the stuff I do is trauma, as you know, but if you're coming with a hemorrhage from high blood pressure, oftentimes, what does that person look like? Well, they're intubated, so they have the breathing tube in, and they're morbidly obese diabetics. That's typically what happens, right? You see it much less so in people that are in good shape. Right? All these diseases are interrelated. They were drilling holes in their heads and things like that, right? They're going to do badly. Most of them do, right? Or they have a big stroke, right? Not a hemorrhage, but just a stroke where the blood has been, the brain has been devoid. You know, it doesn't bleed into the brain, but just devoid of blood. You know, there's a clot in the vessel, so it blocks the blood, and then you get this big stroke. Again, intimately related to hypertension, diabetes, obesity, all things that potentially could be not necessarily remedied, but their risk factors lowered if being on, I'm talking about for the hemorrhage or the stroke, if they're on semaglutide or some sort of similar agent. Right? I think that's what's going to end up happening ultimately, but it's going to take 5 years, 10 years, maybe even more for this to be realized from a data standpoint. But I think that's what's going to happen. Heart attack risk is going to go down. So stroke and heart attack are basically the same, right? I think everything's just going to get better as long as doctors are willing to aggressively prescribe this stuff.
That would be amazing.
Yeah.
I'm gonna give Nicole my chair. She's gonna have a few rapid fire questions for you.
Okay.
Oh gosh, these are the fun ones.
Would you like me to take that over there for you?
Yeah, thank you.
Wanted to make sure you made it.
Morning.
Good
Hi,
morning.
Mackenzie.
What is going on?
How are you?
Come on
Have you been
in.
sitting there the entire time? I know they've been
Come
looking
in.
at somebody.
Like 15, 20 minutes later. I just wanted to come say hello.
Where's your
Have a
motorcycle?
Come into the
Is that
office.
Stevens?
No, I don't want to be on video.
You aren't. You won't there.
Okay, all right. I don't want to be on video.
Right?
How are you guys?
Great. How are you?
Good.
She's heard the semaglutide, talk
Spiel.
a million times. Yeah. Yeah. Well, it's
Every
true.
day. Every
I
day.
It is every day.
Not
Oh,
hard.
it is every day. I mean,
I agree. I think
It's a
everybody should be
lifestyle.
on it. It is
Right.
amazing.
right. I mean, how
Are you
many
guys on
people?
it?
How many people?
Yes.
Yeah.
I mean,
I have
right.
been.
Well, I mean,
Yeah.
how many people do you guys have in here? Honestly,
Yeah.
that come in here, and what's the primary ask? Oh, I got to get in shape. I got to lose weight.
I want to lose weight. I want to lose weight.
And what is it? 95% of your clients in here?
Oh, everybody. Even if they're in shape, Nicole.
Yeah.
That's right.
To lose weight.
That's right.
Yeah.
Okay. Well, here's your solution. Potentially. Which
Or even a
with-
jump start.
Right,
Get
exactly.
used to
At
that
least a
little
jump
jump
start,
start.
yes.
You
That's-
tried everything. Your hormones are fine. Your food is fine.
That's right.
Try this for 8 weeks.
100%.
See if you like it, great. If you don't,
100%.
then you don't. They
Uh,
love it. They
uh,
end up loving it. They stay on it.
Of course they did.
Yeah. I mean, I was a pretty clean eater
Yeah.
before being on it,
Yeah.
but just ate too much of even the clean food.
Right.
Right?
That's
so
right.
it's just able to cut back on my portions.
That's
like,
right.
okay, I don't need the salad that's this big.
That-
This is fine.
That is correct.
So, I mean, I agree with you. I think everybody should be on it and continue to be on it.
That's right. That's
But-
right. Because, humans, we're human. And the tendency is to go, oh, I'm going to have that. I'm going to have that. I'll go out to dinner and we have this big supersized whatever it is, right?
It tastes
We
so
just have
good.
we have no control.
Well, and portion sizes are just huge.
That's
you go to a
right.
restaurant,
Yes.
That's right.
and the plate is this big.
Yes.
That's
And
right.
it's really
It's
3
full.
meals.
That's right.
Yes.
That's right.
It's
But if
sad.
you go to a place and it's not like that,
Then
you're
you're-
like, oh,
you're
the
mad.
portions
You're
are so
pissed.
small.
That's right.
like
Right?
a normal
And you're
size
thinking,
portion, you're like, damn
Right.
it.
That's right. Well, and that just
Yeah.
goes to show you how messed up our brains are, right?
Right.
Because, when you go to places like, like Okinawa,
Mhm.
how do they get away with eating rice? People say, well, rice is terrible for you, right? I say, do you see how much rice they eat?
It's
Right?
the size of
Now,
your palm.
now go to a sushi restaurant and they put one of these sushi boats and there's 400 sushi rolls there, right? This is a different story.
1 pound of
Right?
rice.
So it
Right.
truly is, as you said, Nicole, it truly is, it's a portion size problem here.
Mhm.
And I'll tell you, and I hope nobody's listening to this, but I'm just going to say, people can hear it.
but you can keep it.
No, people can hear it. You can just ignore this. You can just ignore this. People in the clinic, they use, Mackenzie will tell you, they use semaglutide. I'm not going to say it's justification, but to eat more, but it's almost, or to eat crappy. It's almost like
Get away
Oh,
with
people
murder.
do it all the time.
they're immune to the untoward effects of these bad foods, because truly what it is we all know that it's a calories in, calories out problem. So if you ate 2 pieces of pizza a day because that was what you were really, really into, you just love pizza, right? I like pizza. If you're on semaglutide, you can get away with eating 2 pieces of pizza a day, because what's going to happen is that you eat the 2 pieces of pizza, you probably won't really be eating anything else, and you'll lose weight. Is that a good thing? No, it's terrible. But you're going to be devoid of micronutrients. You're going to be devoid of fiber that you need to keep your bowels healthy. There's a lot of problems with doing something like that. But does it work from sort of a thermodynamic standpoint? In other words, calories? Yeah, it does. It does. Because 2 pieces of pizza, even if it has whatever it is, I'm just going to make it up. If it has 1,500 calories and each one is 700, whatever. Okay, I mean,
You're
you know,
still.
you're going to be down there.
Yes.
You're going to be down there. You are. You know,
Yep.
you're going to be down there. And that's what people do.
But your labs will look like shit.
Yeah.
Then we
And-
yell
and-
at you, like, what are you eating?
yeah,
Pizza?
Yeah.
What are the calorie
Well,
limit?
well, it's right. They do.
Okay.
They,
Well,
the
then you feel
labs,
like
you know,
shit,
you see them
too.
in the labs. You know, so it's
Yeah.
not the greatest for your biochemistry, but you can still be, you know, you can still be leaner. You know,
Yeah.
you know, just by virtue of the fact that you're eating less. You know, so I don't know. Ignore that.
Put that one up
Ignore
there.
that.
Ignore that one.
Ignore that. Ignore that. Anyway, I see you have all. Are these the index cards that you ask questions of every single person?
Yeah.
Because they look like they were a little bit sort of worn and aged.
Oh my gosh, yeah.
Yes, many
Amen.
people have
These
been
are
asked.
good.
You guys
Yeah.
actually haven't asked me these questions already
No.
because you haven't.
No,
No,
we didn't get a
we
chance.
didn't do rapid fire with you yet.
Oh.
No,